Hello and welcome. Today, we're diving deep into a condition affecting a vital organ in our digestive system, pancreatic cysts. We'll explore what these cysts are, why they form, how they're diagnosed, and what treatment options are available. Join us as we unravel the complexities of pancreatic cysts. So, what exactly causes these cysts to appear? The etiology of pancreatic cysts is diverse. Some cysts, known as pseudocysts, are often the result of acute or chronic pancreatitis, inflammation of the pancreas. Trauma to the abdomen can also trigger their formation. Others are true cysts, arising from genetic conditions like von Hippel-Lindau syndrome or cystic fibrosis. Still others, particularly mucinous cystic neoplasms, develop seemingly spontaneously, with the precise underlying cause still under investigation. Let's talk about the pathophysiology, or how pancreatic cysts actually develop and affect the body. Pseudocysts are essentially walled-off collections of pancreatic enzymes, fluid, and tissue debris. They form as a result of pancreatic injury, leading to leakage and subsequent encapsulation of these substances. True cysts, on the other hand, often arise from abnormal cell growth or genetic mutations that disrupt normal pancreatic duct formation. Mucinous cystic neoplasms secrete mucin, a thick, sticky fluid, which contributes to their growth and can potentially lead to cancerous changes over time. Depending on size and location, these cysts can compress nearby structures, like the bile duct or duodenum, leading to various symptoms. Understanding how common pancreatic cysts are is crucial. Epidemiology studies show that they're actually quite prevalent. With advancements in imaging technology like CT scans and MRIs, incidental findings of pancreatic cysts are becoming increasingly common. However, most of these cysts are small and asymptomatic. The true prevalence varies depending on the population studied and the imaging modalities used. Estimates suggest that between 2 to 4% of the general population may have pancreatic cysts, but many are never diagnosed. Now, let's discuss the signs and symptoms. Many pancreatic cysts are asymptomatic, meaning they don't cause any noticeable symptoms. However, larger cysts or those that are compressing surrounding organs can manifest with abdominal pain, often described as a dull H in the upper abdomen. Nausea, vomiting, and early satiety, feeling full after only eating a small amount, can also occur. In some cases, cysts can obstruct the bile duct, leading to jaundice, a yellowing of the skin and eyes. If a cyst becomes infected, it can cause fever and severe abdominal pain. In rare instances, a cyst might rupture, leading to a life-threatening emergency. Diagnosing pancreatic cysts involves a combination of imaging and fluid analysis. Initial diagnosis often occurs incidentally through imaging studies performed for other reasons, such as CT scans or MRIs of the abdomen. These scans help determine the size, location, and characteristics of the cyst. Endoscopic ultrasound (EUS) is often performed to get a more detailed view of the cyst and to obtain a fluid sample. This fluid is then analyzed for various markers, such as amylase, lipase, and carcinoembryonic antigen (CEA), to help differentiate between different types of cysts and assess the risk of malignancy. Pancreatic cysts aren't all the same. They're classified into several types. Pseudocysts, as we discussed, are the most common. Serous cystic neoplasms are generally benign. Mucinous cystic neoplasms, some NCNs, have the potential to develop into cancer. Intraductal papillary mucinous neoplasms, IPMs, arise from the pancreatic ducts and also have varying degrees of malignant potential, depending on their location within the pancreas and the type of cells they contain. Solid pseudopapillary neoplasms are rare, typically affect young women, and have a low but present risk of malignancy. Correct classification is crucial for determining the appropriate management strategy. Treatment for pancreatic cysts depends on several factors, including the type of cyst, its size, its symptoms, and the risk of malignancy. Small asymptomatic pseudocysts often resolve on their own and may only require monitoring with periodic imaging. Larger or symptomatic pseudocysts can be drained, either endoscopically or surgically. Mucinous cystic neoplasms and IPMNs are typically surgically removed, especially if they show signs of dysplasia or malignancy. Endoscopic surveillance with EUS and fluid analysis is recommended for many patients with IPMNs to monitor for changes that might indicate the need for surgery. Overall, management is tailored to the individual patient and the specific characteristics of their cyst. Unfortunately, there's no specific way to entirely prevent the formation of all pancreatic cysts. However, certain lifestyle choices can reduce the risk of pancreatitis, which is a major cause of pseudocysts. Avoiding excessive alcohol consumption, maintaining a healthy weight, and not smoking are all important. If you have a family history of genetic conditions associated with pancreatic cysts, genetic counseling may be beneficial. The prognosis for patients with pancreatic cysts varies greatly depending on the type of cyst and its malignant potential. Benign cysts, such as serous cystic neoplasms, generally have an excellent prognosis. Mucinous cystic neoplasms and IPMs require careful surveillance and potential surgical resection, with the long-term outcome depending on the presence and extent of malignancy. Recent research is focused on developing better biomarkers for predicting the malignant potential of pancreatic cysts and improving the accuracy of diagnostic techniques. New endoscopic techniques are also being developed to allow for more targeted and less invasive treatments for certain types of cysts. These advances hold promise for improving the outcomes for patients with pancreatic cysts.